Hello and welcome to Pulse, your podcast delving into all things health, innovation, digital and data. Proudly brought to you by Pulse IT News. I'm your host, Louise Shaper.
And I'm your co-host, George Margellis.
George, great to see you in the studio. Thanks for making time for me today because I know you're coming fresh from a hot breakfast date that you had this morning. Is that right?
I did. This morning, Greek ambassador to Australia, we ran a workshop for 30 influential Greek Australians to discuss how collaboration between Greece and Australia. And I did raise with him the reality of digital health and connected health and how the European continent and Australia have so much in common. So I think that was a great start. Unfortunately, it started at 7 o'clock in the morning. So I had to get out of bed at 5:30 to be down there. But it was lots of fun. And it was interesting because there were a lot of business people. But when we sort of raised issues like healthcare, everyone's sort of going, oh, that's really important. But I think I was the only healthcare person there. So I think we need to do a bit more work in getting the home of Hippocrates to understand what digital health is.
Oh, cool.
But it's been a busy weekend, a couple of weeks, actually. I told you earlier, I had an SMS from my health record telling me that someone was viewing my record.
Ooh.
And even then, about a week later, I got another SMS telling me that someone had put something into my record. So
hallelujah.
After many, many years, I think we talked earlier, I was going for a gastroscopy earlier this week. We talked about how my specialist was quite digital and I did everything online. Well, the private hospital that I went in for my scope is also very digital. So they used my health record and they've uploaded my discharge summary to my health record. So we're getting there. That was an exciting time. And one of my sons went for a blood test and I sent him to the lab. So he actually got his pathology results. So now has a baseline record at the age of 23. So he'll be able to compare with. So the world is getting there. It's slow, but surely going in the right direction.
Oh, that is great to hear. I love it.
How was your week, Louise?
It has been good, but I thought I could tell you about something that happened to me and it can turn into a bit of a public service announcement because I fell for a phishing scam. Yeah, I know, super embarrassing. But my partner, the cybersecurity professional dude, he tells me he's never seen one so sophisticated. So it happened last week and I was out for about a day and a half, lost. So I'm still catching up on the work. Yes. But what happened was, so we've all seen the phishing scams and they come in an email, encourage you to click a link, but you can usually tell because it's like from someone you don't know, or it says it's from George Margellis, but then the email address is, numbers@gmail.com or something. But this one, it came from somebody who I sit on a board with. It looked completely legit, had her logo, everything. And there was a document that she needed me to review. And I've, got a million windows open. So I'm just like, oh, okay. And because it's a board, I do get pulled into all sorts of things that I don't necessarily have much prior warning of. So it wasn't unusual to get an email saying, hey, I need you to check out this document. And so I clicked on it and I saw the link and I saw her company logo. It looked really legit. I wasn't really paying too much attention, to be honest. You know how Adobe wants you to log in and share your credentials? So that's what I did. What an idiot. Yes. So I shared my credentials and went along about my day and didn't think anything of it. 20 minutes later, I get a phone call from someone who I had invoiced saying, hey, Louise, I got this invoice from you just now, but I've already paid that. I paid that last week. And thank God he had, and he was on the ball. I said, I didn't send you an email. Can you forward it to me? So he sent it to me and I was like, holy shit, this thing, word for word, no typos, the same font, everything in my invoice was exactly the same as the one I had sent previous, except the bank account details were different. And thank God he was on the ball. Anyway, I said, that is dodgy. Don't pay it. I quickly WhatsApped to the other people that I send invoices to and said, hey, if you get an invoice from me today, it's dodgy. Just, tell me about it, but don't click on it. And then rang the cybersecurity boyfriend. He did his admin thing. And what we found out was that it took them, 20 minutes to get access to my system, to generate an email, send it out from me. And I was at my computer working the whole time. The mouse didn't move. So they were using some sophisticated technology because also they went into Outlook, and I always have Outlook open. set up rules. And so if any of the people who were getting the invoices or the original board member who had emailed me, it all went to, as soon as you get an email from this person, don't even put it in the inbox, forward it to this external address. And if this guy didn't call me and tell me about the invoice that he didn't think was dodgy, he was just like, I'm sure I paid this, they could have still been in my system and I wouldn't have known about it. And I don't know whether there was some AI that generated that invoice. And then the poor woman who I received the email from, they were in her system for a while, emailing the same crap to other people. Hopefully I'm the only one in her contact list that fell for it, but I did.
That's not great. Interesting how they've turned it around, generated invoices for people to pay rather than attacking your bank account, because you would have noticed if money was missing from your bank account, but you wouldn't have noticed for a month until someone sort of said, but I already paid you for last month's invoice. Interesting.
Yeah, dodgy. So anyway, so there's my public service announcement, PulsePoddies. Don't do as I do and did. And the cybersecurity boyfriend, after all this drama, he sent me an education module he's making me go through so that I don't fall for sophisticated phishing attacks again.
In the good old days, you could tell by the spelling or the Nigerian email address, but obviously they're getting smarter.
Absolutely. Okay, so now I've publicly shamed myself. Let's get to our hot topics, George. So I'm going to start with a story that is a personal one for me. So my partner, Ryan, isn't just a cybersecurity guy. He is a musician. He graduated from playing the clarinet in school band to becoming the lead guitarist in a rock band in the early 1990s before we met. He had long, thick, curly hair, which apparently I'm led to believe would drive the female fans wild. He spent hours every day in front of an amp, rocking out and honing his craft. Now, fast forward to now, and his Generation X hearing is pretty much shot. When we go out for dinner, he has problems hearing the conversation amongst the noise of the busy city and the restaurant. So recently, I was a good girlfriend and I made him an appointment to get his hearing tested and be fitted for a hearing aid. Of course, he's a man, so he didn't go to the appointment. Anyway, not to air our couple laundry, but could you imagine our excitement after last week's Apple announcement that the AirPods Pro can now serve as a hearing test, hearing protection, and a hearing aid? Apple have stated that FDA approval is just in the pipeline. And the even cooler thing is it's not an updated piece of hardware. It's just a software update that's required to turn your headphones into a clinical level hearing test and over-the-counter hearing aid. George, this is just the most recent example of medical grade consumer devices for supporting health and well-being. What's your hot take on this one?
Look, I think it's a very exciting thing. So first of all, I have to say I'm not an Apple fanboy. I'm actually an Android user. I'm not a big fan of closed ecosystems. But having said that, I am very impressed with the latest Apple Health announcements. The hearing aid announcement was of great interest. I don't know if you know this, Louise, that back in the 1980s, when I first graduated as an optometrist, I did a course run by then a company called British Optical. It was like a 2-day training course on audiometry. And that made me and I use air quotes, qualified hearing aid consultant. So back in the day, I did a couple of hearing aid tests for people. I actually had the audiometric device. And, hearing aids back then were 4 weeks' wages. Yeah, they were a couple of $1,000s each. They were primitive. They really didn't do much. And as you pointed out, the rock and roll era has led to a lot of people requiring them. So the fact that now your smartphone can add that functionality through a standard set of those little white AirPods, and everyone's walking around with those little white AirPods. And rather than those little white AirPods making you deaf, those little white AirPods are going to make you hear. So that's really quite exciting. But that same announcement also had a really interesting thing about sleep apnea. I don't know if you saw that as well. So they're developing a sleep apnea detection algorithm. And when you look at the health risks of old men like me, sleep apnea and atrial fibrillation are two of the major health risks. And between the Apple Watch and the AirPods, we now actually have some really amazing technology in consumer grade devices. So I think it's a big change. I went and did some homework. So I went and looked up, but there was a document that came out a year or two ago from Apple talking about their health initiatives. And they really are doing some really exciting stuff. I always wondered whether a company like Apple would actually get actively involved in healthcare, but it seems incrementally over time they've added more to it. And then you've got HealthKit, and now you've got the connectivity with Epic. They're one of the big companies using Fire. So it really raises the question about to what degree will consumer technology, which is available in the tens, if not hundreds of millions, be available to provide us with new access to new information.
Oh, it's so exciting. And, like again, with the Apple thing, if Apple wants to sponsor this podcast and you're listening, we would love to accept your money. But at the moment, we do not have sponsorship from Apple. So it's more about this medical grade devices that are consumer devices. It's impressive. And I read that document as well when it came out from Apple. And I talk about it a lot in some of the keynotes that I give because they see healthcare as being critical, a key component to their ongoing growth. And when you're talking about growth, Apple, I looked it up this morning, their market cap at the moment is $3.3 trillion. Now, to put that in context, that is double Australia's GDP. And there are actually only 4 countries that have a higher GDP than $3.3 trillion, which is US, China, Japan, and Germany. So the fact that Apple, they're doing pretty well, but now they're seeing that healthcare is going to be an increasing market for them.
Well, it's interesting because $3.3 trillion, I think that's half the US expenditure on healthcare on an annual year. So from that perspective, it's an opportunity for growth for new revenue streams. I think we'll be watching it with interest. You may actually see me at an Apple store speaking to a Genius bar in the future. You never know.
All right, then. If you need a hearing aid now, I looked it up and you're looking at minimum $1,000 up to sort of $6,500. These Apple AirPods, there's probably a certain range that they will work for, but they retail for $400. This is much more affordable for people.
And interesting, just today, there was another story on the news, a new study showing the correlation between hearing loss and dementia. So therefore, this becomes a preventative healthcare task as well. You have to get Ryan to tell him that if he put on his AirPods and he can prevent it having dementia, that might be the thing that drives him there.
Okay, then. Well, I will report back in future if I can get Ryan to get his hearing addressed and if this is the secret sauce. In a related story, bioacoustics. So, if you haven't heard the term bioacoustics, it's a field that combines biology and acoustics. Google have trained an AI on 300 million human audio samples like coughs, sneezes, sniffles, laboured breathing, and they've used that data to train an AI foundation model to identify signs of diseases like tuberculosis. I believe they've teamed up with an AI startup in India, which is focused on respiratory healthcare, to incorporate this technology into smartphones. Google's AI model is literally called HEAR, HEAR. It stands for Health Acoustic Representations, and it utilizes sound signals to anticipate early signs of illness, providing an innovative tool for medical diagnosis. And when it's an app on a phone, the plan is to screen high-risk populations, especially in regions with limited access to costly diagnostic devices. What do you think about this one, George?
Again, a really exciting initiative. I wonder whether the acronym came first or the technology or whether they linked them all together. Again, back in the old days when the doctors were taught to listen to people's chests and listen to people's speech and listen to people's coughs. And when I was a junior doctor, one of the respiratory physicians could walk around the ward and listen for breathing sounds and diagnose from them. So the concept's not new, but using AI and using that ability to scale it, because the professor was amazing, but he's only one of him and he could only walk around so many rounds. So I think it's a great initiative. And again, looking for those biomarkers that we just don't identify in the real world. The fact that we can correlate, and they may not be causation, but even if they are just correlation with disease, that still gives us a tool to build upon. And as you point out, there's huge parts of the population who don't have access to healthcare at all. So this is not a matter of replacing respiratory physicians. There are people who will never see a respiratory physician in their life. So therefore, giving their carers tools to help make better decisions is great. And I guess the question then becomes, what other biometrics can we use in healthcare? And I think that's the exciting sphere where a lot of innovation can come into play.
Absolutely. And the other conditions like COVID, I remember being pitched to by a startup in 2020, and they were pitching that they could actually develop this technology. So you'd be able to cough into your phone and it would tell whether you had COVID or not. Now, I'm not sure whether that particular company is still around, but there's lots of conditions that are related to laboured breathing as well as the sniffles. So I'd be keen to see where this goes.
The sensors and the technology is picking up so greatly. How do we take advantage of it? And this is the opportunity for innovation to leverage those new technologies.
And George, what do you think about our doctor friends? How long will it take before they go, oh, you've got some hearing issues. Have you tried some Apple AirPods, or cough into this app, please? This is not a visual medium. George has a massive, big laughing smile on his face with my question.
Look, when the first one does it and gets that story on current affairs and starts getting that big following, then, like I said, it normally takes 17 years for new technology to work its way into healthcare. Maybe we can shorten that period by making them listen to PulsePod, and that'll drive implementation of new innovative technologies.
Great. Our next hot topic is in Australia. There was some really big news last week. Australians will no longer be discriminated against by insurers on the basis of our genetics. Yes, currently, if you get a genetic test in Australia, you're obligated to tell your insurance company about it and disclose the results. And those insurance companies, they're allowed to use that genetic test results when assessing applications for policies such as life, trauma, total and permanent disability, and income protection insurance. This is now changing. This is a great thing. It'll no longer be allowed to happen. I personally wrote a submission to the government when they were conducting the consultation earlier this year. And the reason I'm really passionate about this is because knowledge is power. Knowledge opens up choices. If you have an increased likelihood of developing a condition, then you've got the option. You know about it. You can take preventative measures to try and limit its impact or make it milder if that's an option. For other conditions where that's not possible, at least you can plan and prepare. And for some conditions, genetic testing could actually save your life. So I wanted to give a PulsePod shout out to Dr. Jane Tiller at Monash University in Victoria, because she's been campaigning for this change for 8 years. And I also really thank the politicians who listened and acted. I had a look around what happens in other countries, and I'm glad to say that Australia has actually caught up now with Canada, the UK, and France. But in most other countries, they still haven't actually addressed this issue. What are your thoughts on this one, George?
When I first heard this story, I thought, oh my God, this is one of those things where the Americans have beat us, because I'd heard about the Genetic Information Non-Discrimination Act in the United States, which came into effect in 2008. However, it only applies to health insurance, not life insurance. So the Americans still haven't, but they do have state-by-state legislation there. Look, I think it's very important, mainly because it removes a major impediment for people to have a genetic test. I mean, there was always that, I'm not going to have this genetic test because if it tells me I have X, Y, Z and I get denied life insurance, that's a significant issue.
Yeah, and I believe it's not necessarily easy to get a genetic test in Australia. That's a real problem. I know people who want genetic screening done because they do have serious conditions in their family, and they have a really tough time even getting access to the screening and getting it paid for. So I'm hoping that the government, they've basically put a signal out to the market. And so hopefully the market responds with new companies and to actually increase the affordability and the accessibility of genetic testing as well.
It's also an opportunity. We always talked about genomics being part of precision medicine. The bigger the data set, the more data we have from people with longitudinal records. And this is where we tie our My Health record with our genomics data. The secondary use enables us to pick up correlations and causations that we don't recognize yet.
Well, we'll have to revisit this when we get our friend Eric Dishman on the show in a future episode, George.
Absolutely, yeah. And there was an announcement in the last budget about a Genomics Australia project, but it's still very nascent. So this may be the opportunity for that to really take off.
In our final hot topic, we're heading over to the UK. Now, we did promise that we would revisit the NHS once the government's review was published. We spoke about this in our second episode of Pulse. Well, Lord Darzi's done his review, his verdict has landed, and it's all anyone in England and the NHS can talk about. Friend of Pulse, shout out to Dr. Keith Grimes, even wrote a custom GPT to assist people in reading it. I'm going to put a link to Keith's custom GPT that he wrote in the show notes, so if anyone else wants to try it. So I decided that I would put Keith's GPT to the test, and I asked it to write a one-sentence summary of the report findings. And this is what it said. The 2024 Darzi report reveals that the NHS is in a critical state, with declining public satisfaction, worsening health outcomes, and operational pressures. So then I thought, okay. So I asked Keith's GPT what was the mood of the report. I said, was it hopeful or disastrous? And it said, the mood of the 2024 Darzi report is cautiously urgent rather than outright disastrous. While it acknowledges the severe challenges facing the NHS, Lord Darzi stresses that although the situation is critical, decisive action and a focus on public health, reducing inequalities and addressing systemic issues could still restore trust and improve the NHS. So, while the findings are grave, the tone isn't entirely hopeless. It points towards opportunities for recovery and renewal. the Prime Minister Sir Keir Starmer and Health Secretary Wes Streeting have pledged a 10-year plan to fix the NHS. And then finally, George, I just couldn't help myself. So I decided to put this prompt into ChatGPT and I said, how would a sweary Australian podcast host summarise the report's findings? This is what it said. The NHS is bloody falling apart, mate. Public trust is shot. Life expectancy's gone to crap and the whole system's barely keeping it together. If they don't get their act together soon, we're all stuffed. Time to stop sugarcoating it and fix the darn thing. So, George, sorry, I'm not very good with the Australian accent. George, how would a Greek Australian podcast host summarise Darzi's report?
Good question. I guess when you look at it, you'd sort of think, oh my God, this is a catastrophe. But then one thing I discovered in the UK is when in doubt, have another review. And in this case, the same guy who did it back in 2008 and see if you can find a different answer. And shock horror, the answer is pretty much the same. It's just the problem has gotten bigger. Throw in a global pandemic for a good mix and then get a call to action that has been unheeded before, but hopefully a change of government with a greater social conscience may respond to it better. A big part of the problem at the end of the day is money. Not enough is spent on healthcare. What is spent is not spent wisely. And the expectation that healthcare workers will continue to work in poor conditions for poor pay and be okay with being the scapegoat for all of society's ills will continue. Meanwhile, bankers, insurance companies, tech companies, lawyers can earn a lot of money, get the weekend off, say they have the answer to everything, but refuse to share it for proper scrutiny. Sounds pretty familiar, doesn't it? It's a commonality across this report. I do note that Lord Darzi's first recommendation is re-engage staff and re-empower patients. That's something we've been talking about on our podcast for a while, isn't it, Louise?
It's sort of a favourite topic of ours, yes.
Yeah, and it goes back to those two basic tenets of the IHI's quintuple aims: staff being happy, care providers being happy, and patients being happy. So I can't see where the disconnect is, but he says that they have to drive care closer to the home by hardwiring financial flows. We've had that discussion too about reimbursement drives policy. Simplify and innovate. Sounds pretty good. And drive productivity. When I speak to my colleagues in the hospital, they say, well, we're working at 110% capacity. How do you ramp that up? And then there is that classic call for a tilt towards technology. I think it was a 1997 report in the UK said requires that. So we keep on getting these revolving door type solutions, but keeping in mind, the NHS actually does deliver cost-effective care compared to other parts of the world. So there's no easy solution. Hopefully they get it right. They could start by paying clinicians better, although I have to be very careful here because Australia does rely very much on British doctors jumping ship and coming over here to work. So
we do.
If they pay them too much over there, they may not come over. Give them the right tools, give them some work-life balance. And ultimately, I guess it's finding the money. I often get upset about these discussions around, but healthcare costs so much money. But when you spend money on healthcare, you actually spend it within the ecosystem. So it doesn't actually necessarily even leave the city that it's been delivered in. So there's an opportunity for a healthcare economy which gives people better health outcomes, gives healthcare providers a sustainable way forward. And then we need to start looking at tweaking how we deliver healthcare. This is where innovation really comes into play. We're talking about delivering care closer to home. Well, does that mean that our homes need to be smarter so they can take part in our healthcare? Those same AirPods we were talking about earlier can also measure pulse rates and heart rate variability. And we've got sensors in the home that can pick up people's respiratory rates, all those sort of data points that we can start leveraging to provide a more comprehensive healthcare service and start thinking differently about who their healthcare providers are and what they do as part of their services.
What I'm really interested to see is, we talk all the time about preventive health, which, is sort of an oxymoron term. Someone needs to change that. But the idea that we should shift our healthcare system away from diagnose and treat, well, at least as its sole focus, to being proactive and a predict and prevent approach, which we can enable by technology. And that's certainly one of the recommendations in Darzi's review. And I often think, how bad does a healthcare system need to be? How big of the crisis need to be before governments and indeed a populace will actually start taking that, prevent and predict option as seriously as it really needs to be? So I guess time will tell, but it'll be interesting to see if this is the time in the NHS.
One of the things we need to really start thinking about is that we are, to some degree, the victims of our own success. So the healthcare system and the public health initiatives like stopping smoking and improving physical fitness has led to us having an older population. that older population is more prone because when you look at it, age in itself is a risk factor for many of these diseases. So we've shifted the curve so that we now have 70 and 80-year-olds whereas we never had them before. Our healthcare system was not designed to manage that. And we've had lots of discussions between the two of us around longevity science. But the reality is then that will then shift our 70 and 80-year-olds to 90 and 100-year-olds. So what is that going to look like? We really have to be careful that we don't sort of think, oh my God, the healthcare system is falling apart. It's actually done a pretty good job in getting us to live a lot longer. And whilst there are some challenges around health span, the reality is there's a lot more sprightly 80-year-olds walking around now than there was 30 years ago. So we're doing something right. But then we just need to keep on adapting. What was that? The famous quote around evolution? It's not the smartest one. It's the organism that can adapt the best that's most likely to survive. We need to have an adaptable healthcare system as well.
Yeah, absolutely. And George, what you were just saying reminded me of a conversation we had back in the early days of our relationship. It's always stuck with me. We were having some sort of philosophical discussion about healthcare and what's needed to fix the system and money. And you said, well, there's one thing that the healthcare system could do which would really fix a lot of the budgetary problems. And I was like, oh, what is it? And you said, encourage everyone to start smoking. Do you remember that?
The majority of our healthcare costs are in people as they age. Back in the 50s and 60s, men my age dropped off in their late 50s, early 60s because they smoked heavily and they had heart disease and lung disease.
Not that we're advocating for that, but
definitely not advocating for it. And I am a lifelong non-smoker. But like you said, we need to accept the changes we've brought in do have benefits, but those benefits have led to a new set of problems. They're unintended consequences. And we just need to keep on iteratively improving our system. And we do that by focusing on patient outcomes.
Absolutely. Well, always great chatting the hot topics with you, George, but time for us to have a brief break. And after this break, we'll be back with our special guest of Pulse, Matthew Holt. He's basically been the digital health guy in Silicon Valley since before we called it digital health. We'll be talking with Matthew about the US election, what's happening in health startups and venture capital, and what other countries can learn from the US's experiments in the retailisation of healthcare. We talked about Bunnings recently. Well, in the US, this is where that sort of all started. So we'll have Matthew on the show after this brief break. If you have any connection to Silicon Valley and digital health innovation specifically, then today's guest doesn't really need much of an introduction. Matthew Holt is one of health technology's OGs. In the early 1990s, yes, kiddies, before the internet, Matthew was writing and speaking about healthcare IT. In 2003, he founded the Healthcare blog, one of the first blogs ever in healthcare. And today, that blog is the leading platform for healthcare opinion, news, and interviews with over 100,000 visitors per month. In 2007, Matthew co-founded the Health 2.0 conference series, which quickly became the leading health tech in Silicon Valley conference with events and chapters in 5 continents, and he sold it to HIMSS in 2017. Now, Matthew advises health tech companies on market entry and product development. He lectures globally on health and health tech and teaches digital health entrepreneurship and product development at the University of San Francisco. Hailing from the UK, but based in San Francisco for 3 decades, Matthew has unparalleled experience. He has seen the pitch decks, the lofty valuations, seen real reforms, and also witnessed spectacular failures. He knows everyone, and he knows where the bodies are buried. Matthew is known for his strategic foresight and candid commentary on industry trends, so we couldn't think of a better person to talk with about what's happening in the USA when it comes to health innovation. Now, Matthew does describe himself as the healthcare curmudgeon, but we will let you, PulsePoddies, decide for yourself. Welcome to the PulsePod studio, Matthew.
Thank you so much, Louise. It's been a while since you've invited me to speak in Australia. I wonder why.
Oh, it's so good to have you here. And, we're not just Australia. Anyway, we're global.
But Australia is the centre of the world. So,
well, all podcasts are global, and Australia's always been the centre of the world, as we know.
Excellent. Great to have you on board, Matt. Good to see you again. Let's kick straight into it. I mean, obviously, things are hotting up over the United States. We had the opportunity to watch the debate a couple of days ago here in Australia. And so the most important thing, do you have any pets and are they okay in America?
So I happened to be that night, I had a very rough night's sleep, and one of my dogs spent a lot of time, waking me up and, making noise and whatever. And at about 6 a.m, I said to him, "Oi, mate, I'm an immigrant here." On a serious note, it's both appalling and quite clever distraction, right? Because now for the last week, all that's been talking about has been demonization of immigrants. I mean, there wasn't much in the way of serious policy or politics in the debate. And this all just got washed away because we're having so much fun about the cats and the dogs.
Well, you do head off to the polls on the 6th of November. And I was really intrigued, Matthew. You wrote a recent blog post where you discussed how the results of the election, particularly under a potential Harris administration, might actually not lead to much in terms of healthcare policy. Can you tell us why you believe that the impact would be minimal, especially in comparison to past election cycles?
Sure. So it takes a lot to change healthcare policy in a big way in America. It takes been lots of big runs at it. And the last one, which was successful, was the Obamacare Act, ACA, in 2010. Previous to that, you have to go back to Medicare and Medicaid in 65. Nixon had to go. You may not know this, in the early 70s. Jimmy Carter had to go, didn't work. Clinton had a well-publicized go in the 1992-94 period. Very hard to do a big change, right? So anything else that's changed has tended to be very incremental and very slight. And you actually did have a bit of a change in the what's called the Inflation Reduction Act, the IRA, which is a strange name for an English guy. But the IRA was predominantly about clean energy and some other areas of life. It had two healthcare impacts. One was that finally Medicare is the American state single payer system for those over 65 only. So we believe in single payer, but only if you're old, was finally allowed to negotiate the price of prescription drugs, because based on the power of the pharmaceutical lobby, the American government never been able to negotiate the price of drugs. Instead, just had to take the price they've been given. Hence, drugs in America cost roughly anywhere from 3 to 10 times what they do anywhere else in the world.
Yeah, for some conditions, it'd be cheaper for you to fly to Australia and get your drugs here. Forget about Mexico.
My line on that is that actually, if we want to, given that 150 million Americans well overweight and obese and probably should be on Ozempic, if we have this fantastic army and navy, we should just go invade Denmark. It'd be cheaper just to take it over than putting everyone on Ozempic at the cost of $12,000 a year, which is what it is here. So they've done that, and now Medicare, or CMS, which runs Medicare, has actually now negotiated the price of 10 drugs, and they're talking about doing more in the future. But they're still 2 to 3 times what they are in other countries. But that's a slight change, which is going to make some difference for some people. And Harris is talking about a $2,000 Medicare total cap. Of course, the bill may get turned back if she loses it. So that's one thing. The other thing that happened in the IRA was that during the pandemic, there was a bigger government subsidy to buy into the ACA plans. That is for people who are not receiving their care from either their employer or from the government, because it's Medicaid for the very poor. And those subsidies were extended, but they will run out in a couple of years. So that's how the Americans got from about 15% of the population being uninsured down to about 6 or 7%, because they basically subsidized the ability for those people to buy into a private health plan. I would say these are minor things around the edges, and they've already happened. So if you were to go to where Harris was when she announced her run for the presidency in 2020, she actually said that she wanted to do Medicare for all. So she was talking about doing that in 2020. Biden, in his pitch to the presidency, said he was going to extend Medicare down to 60 or 55. Both those would be very major changes to the system. And I don't see any interest. Biden, they brought that up when he got into power. Harris has not mentioned this again. She's only talking about prices. I mean, people are obsessed with price in general because of the high inflation we've had. Obviously, it's a big deal. So every time she can mention, we brought down the price of drugs, we brought down the price of insulin and capped it at $35, where it used to be $200, and we'll do more. That is the kind of stuff she's talking about. But that's really just around the edges. The other area, of course, is going to be a huge amount of focus, which is, I hope, peculiarly American, is women's reproductive health. But even if Harris gets in, wins the House, wins the Senate, and breaks the filibuster, which she'd have to do in order to pass a nationwide Abortion Rights Act, it'll only take American women back to where we were in 2020 or even in 2022. Sorry. So, I wouldn't call that a radical change.
And obviously, if the other side wins, I mean, he has a concept of a plan, so you should be pretty confident of that.
It's interesting because when the ACA Obamacare was passed in 2010, it didn't really get going and have any implementation until 2013, 2014. And by then, it was actually getting quite popular because up until that point, health insurance companies in America had been allowed to deny people insurance based on pre-existing conditions. So if you had almost any kind of medical record saying you had any kind of condition, you had to buy on the open market. You couldn't in many states. In fact, I tried to buy once in California. was told that I had a knee surgery and therefore I wasn't insurable. So, really happened to real people. And once people figured out that the ACA gave you a way you could buy a health plan and didn't let them reject you, it became quite popular. Now it's actually very popular. So I don't think they'll seriously have a go at trying to go after it anymore. I mean, in terms of making a significant change to the healthcare system in the States, I don't think that's going to, God knows what else he will do. He may take us out of NATO. He may do all kinds of crazy crap.
So Winston Churchill is quoted as saying they can always rely on the Americans to do the right thing after they've tried everything else. Do you think we're nearly at that point of they've tried everything else?
We hope so.
Cool.
Okay, so what are your thoughts in terms of the election result and how that might impact actual innovation and startups? So there's a lot of venture capital money and billionaires dumping money into Trump because they think his policies will benefit them when it comes to their cryptocurrency investments and those sorts of things. How do you see the election result impacting the innovation side of the economy?
Depends if you think that cryptocurrencies are actually innovative or just fraudulent. And I've yet to see, it's had zero impact as far as I can see anywhere in the world other than around the currencies and speculation. The thing that is more, I think, troubling to the small minority, but to some in the kind of Silicon Valley community who tended to be more Democrat, tended to be more socially liberal, and tended to be more like the Obamas and like the Clintons, has been the attitude of the FTC, which has, the woman runs like Linda Khan, has been coming after big corporations and threatening them like Google and others on the monopoly side. There are still startups being bought by big companies like Google and Microsoft. It's still happening, but it's a little less aggressive than it was. And between that and the high interest rates, there's definitely been less activity in the exit side for all those startups. And that's what they're really complaining about. This isn't some highfalutin, we believe in the freedom of the individual to innovate. It's we want to get our money back for the companies we've invested in. Let's be clear about this. And frankly, if you listen to what Harris was saying at the convention, she's interested in getting a way forward for AI and American domination and the whole very aggressive domestic industrial policy, which is mostly with the CHIPS Act. What is that all about? That's about getting the supply chain of chips back to America and getting some control and getting some of the value add in all these new chips, especially around AI, into America and not giving it all away to China. There's much support from Silicon Valley for that. And really what we need to see is inflation under control, which I think it is, and interest rates coming down, which I think they will do. And let's, fingers crossed, hope we can have a very soft landing or recession of the economy. And then Silicon Valley will charge off again. But you're still seeing, especially in AI, a good amount of investment. So I'm not that concerned about it.
One of the last acts of the Obama government was the 21st Century Cures Act, which has obviously has driven a lot of that innovation. Is that still being adhered to? Is that still in place?
So this is really about access to data, which is not just an American thing. But so it's very confusing in America because it's such a diversified system and people have records in so many places and see so many doctors and, your records with the insurance company and with multiple providers. And the idea of the 21st Century Cures Act, one part of it was around improving access to data. And that's, I think, gone pretty well, with the exception that the major hospital systems are mostly in charge of that data. There's pretty good access for innovative companies to get to the data, so it's not bad. There's still some nuances around the edges. But in general, your doctor or your provider organization, if there's data with somebody else, will be able to get it in about 90% of cases. So, it's not bad. Now, have we created an entire thing where all Matthew Holt or any patient's data is available anywhere to anybody in a format that you could then build entire new companies on top of it, which was kind of the dream? Not really. You are starting to see the creation of hybrid and online only companies looking at particular types of care, whether it's menopause for women or different types of mental health, GI care or whatever, and which are new provider organizations, venture backed, and they are usually able to get access to data. So you're starting to see this. So I would say, is it easy? It's not easy, but it's doable.
So it's obviously much easier than what it was.
It's easier, yeah. Right. The problem / situation is that over the last decade and a half, American provider organizations have consolidated. Hospitals have bought other hospitals, and now you have very large, usually non-profit, but still very, very profitable provider organizations who are usually using Epic. And it's hard for those organizations to start doing things that look like they may be helping young upstarts. So that to me is the underlying problem. And that's going back to the thing about Linda Khan and the FTC. Maybe they might start trying to break up some of those hospital systems and some of the insurance companies. I mean, I doubt it. They might do, but that's a way. But I think the goal of having a massive data lake with 325 million people's records in them easily available to build innovative new kind of cures and do new types of treatment on is still a bit of a dream.
So I wanted to ask you about the retailisation of healthcare in the US, because there is a growing trend. It sort of started with you guys. You've got Walmart, the pharmacy chain CVS, Amazon offering healthcare services themselves virtually as well as in bricks and mortar storefronts. And it's a really interesting idea that these non-traditional companies enter the market and they compete for patient dollars in innovative ways. What do you see as the driving forces behind this shift? Is it really just the lure of profit? And how have you seen it reshape the healthcare landscape? And the reason I'm asking is because that is now starting to happen in Australia and in other countries as well.
So I think there are two things going on. 5 years ago, it looked like it was going to be a much bigger deal than it has been, right? So that's the first thing. So I think the main reason is that in America, there is very poor provision of primary care because we pay our specialists much more than our primary care doctors. So we have a very low number, relatively speaking, of primary care docs and very poor access to primary care. So, and in fact, the reason Walmart got into the business, which they now, by the way, just got out of, asked people coming into Walmart if they had a primary care doctor. 40% said no. And then they asked the remaining 60% who said they did have one, who their primary care doctor was, and half of them didn't know. Didn't know their name, right? So the answer is
Okay.
No one has very few have a primary. So all these retail organizations looked at this and went, well, we have an opportunity to do that. Now, the problem with this is that in America, primary care doctors are politically not very powerful and they don't get paid well. And so it's hard to make money just doing primary care. The way to think about primary care is like the Kaisers of the world, where you put primary care group, the specialty group all together, you get them paid one lump sum, and then you make money by reducing the amount of money you spend on specialty care, and you hold on to more of it in the primary care area, and then you are able to essentially take a bigger cut if you avoid unnecessary surgeries, avoid unnecessary hospitalizations, avoid unnecessary visits to the emergency room. You look at the retail plays that have been, is that Walmart just set up its own primary care, didn't really get into that, can we get coverage for the entire person? And they were losing money hand over fist, and that's why they stopped doing it. Walgreens is in a similar situation. It bought a company called Village MD and another one called Summit MD, which was an East Coast primary care chain. And they paid way, way too much, and they're really struggling, and they're going to stop. They're already cutting back on what they're doing. CVS bought a company called Oak Street, and Oak Street was for seniors. They cover Medicare Advantage patients, and so they get what's called the full risk. They get all the money, and if they don't spend it in specialty care or hospitalizations, they get to keep it. So they make money on primary care, not by delivering primary care services, but by delivering enough of the right care. But it also turns out that it's a massive opportunity because there isn't a good connection in general between Americans and their primary care docs. What you have seen being successful is a lot of what's called urgent care centers. And there have been many of those have popped up around the States in the last decade.
So that's what you've got an emergency and you head down there in person?
Yeah, it's more like I've got something minor, like I need a stitch or whatever, where I don't have to go to an emergency room. It's much cheaper to go to urgent care. Urgent care is more expensive than primary care, but it tends to be covered. Those urgent care centers have grown, and sometimes big hospital systems have used them as a feeder to get people into their hospital system. But I think the idea that you could go to a big pharmacy chain and get more services is a great idea. The economics of it in America haven't really worked.
So it's interesting. I mean, we have a similar challenge here. Primary care was attractive for young graduates many, many years ago, but through some changes in the programs and specialists getting paid significantly more and having a higher profile, we've seen a dearth of primary care. There's been attempts of retailisation here. There's probably not as dramatic as over there, and there is some restrictions around what pharmacies can do, and that's about to change. But the one thing that we thought always was going to happen, of course, was that all this care would be virtual. 24/7 virtual services. That doesn't seem to have taken off to the same extent that we all thought it would post-COVID. But now we're in the new world order. What's happening with virtual care over there?
It's extraordinary that it really went back as fast as it did. One is that people got used to it. So for minor stuff, you are seeing it being made available to most people. I'm a member of One Medical, which is now owned by Amazon, and they have a virtual thing. And actually, I use that probably 2 or 3 times a year, and I see my doctor once a year. So it has picked up a bit more, just not to the extent you thought it might get to. It's roughly coming in around 5 to 8% of visits. Now, it wasn't like 1% pre-pandemic. Where it's really taken off is in mental health. You're starting to see some intelligently built hybrid care companies who are trying to use virtual care first and then have a way for getting you into the rest of the system. So, for example, Lyle Berkowitz is running a company called KeyCare, which is basically a virtual first wraparound for major hospital systems. You're seeing a few others like that, where they figured out how to make the transfer between the virtual and the real. And I think people will start getting to that. I personally had a couple of amazing specialty consults. I had one for a bad back, where in this very office I'm sitting in front of you, they had me walk up and down, jump on one leg and do stuff. And when I said, yes, this hurts and that hurts and it hurts there and this part of my back hurts, 2 separate specialty docs both were able to diagnose the exact part of my lumbar spine that hurt and got it dead right. So, do you need to see somebody in person? Maybe not. But the old tradition of can I see someone in person is there. And I hate to say it, but in the US, if I got you in the room and I can figure out there's something else wrong with you, I can usually bill you some more. And that's much easier to do in person.
Yeah. Do you want fries with that? You guys did specialize in that.
Absolutely.
It's interesting because here we've seen a couple of primary care providers do telehealth here, but the biggest challenge we faced in Australia was that something like 90% plus of all telehealth during the COVID pandemic was done by phone. And it was literally just a short conversation. So we didn't get the same effectiveness out of it.
And you can do a ton over the phone. You can do a ton over video. And to my mind is that people like us in digital health have done a really piss poor job selling it because it's much easier and more useful as a patient than having to put your kid in the car and go across town or get on the bus or whatever. Provider systems, organizations have said, we don't quite understand this and we're not quite set up for it. And we liked the way we were able to do stuff and bill for it before. So nothing changes that fast.
Once again, it's the culture.
It is. So we are now paying in America, and it has picked up for things like remote patient monitoring. The whole goal of can you monitor chronically ill people is getting closer and closer. And I think that is still coming. It's just a generational change, not a 5-year change. And hopefully some of us are still around to see the end of it.
Looking out.
I'm not sure.
All right. Well, that's a good segue. What else are you seeing in the health startup space, Matthew? Is it possible to actually have a pitch deck without AI all over it and it's going to solve world peace?
Sorry. Not if you want to raise money, Louise, now. It is extraordinary how much money has gone into the AI side of things. The startup scene, there are still a ton of people building startups and trying to do it. And there's a little bit of money being raised. But the craziness we saw when everyone was raising money 3-4 years ago, and even the sort of steady increase of it into the consciousness that we had in the time I was doing Health 2.0 all the way through the 2010s, that's kind of died down. And I think it's much more instead of, we're having this whole new technology and create a whole new system. It's going to be retail, and it's going to be online, it's going to be hybrid. It's much more now we have these big healthcare systems, and they're slowly going to start using new ways of doing things, and they'll do it at their pace. I got to tell you, because so much money was put into startups basically 10 through 3 years ago, go back to that exit thing. A lot of venture capitalists and others are waiting for that exit. And until that happens, you probably won't see the level of excitement that we saw a few years back happen again.
Yeah, the money's tied up and capital's not cheap anymore.
We'll see what happens with interest rates and whether inflation really has been vanquished and yada, yada. We might get back to that. And we'll see how much comes out of AI.
Every startup pitch deck I've seen tells me that it's an AI-enabled system which solves X, Y, Z problems. And when you ask them to dive deep into the AI, it's usually very, very basic. Was it about a decade or so ago, Vinod Khosla told us all that doctors were going to be replaced by AI. Is my good friend Vinod Khosla still pitching that deck? Are we still going to be replaced?
I think Vinod is, he changed his tune. He says 80% of the work doctors do will be replaced by. I think he's right. It's very similar to the driverless car thing, right? You looked at it 10 years ago, you're going, wow, by the time mid-2020s, by about now, no one's going to buy a car and drive it. Now, you can get in a Waymo driverless car and it works incredibly well. And it's probably the safest way you'll drive around San Francisco. If you haven't done it, it's very weird. Both terrifying and ordinary. You get in and there's no driver, but it's much safer than the average driver. But it's not everywhere. And I think that's the same thing. You're going to see little pockets where it grows very fast. And it's going to kind of be disappointing for a while. But eventually, I think we come back here in 10 years' time, it'll all be driverless cars. And a lot of doctors will have been massively augmented and in some cases replaced. Just because of the lack of therapists and the demand for mental health, I cannot imagine an AI-based avatar mental health therapist will not be frontline.
And I guess it's also that thing of does the real doctor utilize those tools to improve their quality of care as well?
I've had 2 or 3 pitches to people who've built a little tool using current LLMs. They're using Claude or OpenAI or whatever, and they are literally building differential diagnosis and support. One of them was building a tool which enabled the doctor's way of behaving and their bedside manner to be duplicated so they could talk to multiple patients at once. Are we ready for one doctor's practice to have like 15 identical versions of that doctor that practices the way they do the intake to take all that first conversation away?
But if it goes to the point we spoke about earlier, I mean, say if there's a shortage of primary care providers, then an AI-enabled primary care provider can help fill those gaps. I think there's those opportunities.
I agree, but don't forget, there's also, 2/3 of the world where we don't have access to primary care. I'm surprised it's taken this long because people have been trying with this for a few years. But the LLMs are really very, very interesting and they're very good.
Well, Matthew, thank you so much for joining us here in the PulsePod studio. It's always a pleasure chatting with you, and I look forward to you coming back maybe after the election and you can give us an update on what's happening in the US.
Thank you so much, Louise. Thanks, George. I will hope that, you guys got a spare bedroom for me. I might need it by that stage, right?
Yeah.
I think the Kiwis closed the border after the last time.
That's right. There was a large flurry of Americans to New Zealand in 2016, 2017. So Australia may be the next best place. Thanks again, Matt. It was good to see you.
All right.
See ya. Now it's time for an update from our correspondent, Kate McDonald from the Pulse AT News Desk. Kate, it's always a pleasure to have you on the show. How are you going today?
Fantastic. And like you guys, Pulse IT has been ranging all over the world in the last week or two in terms of our coverage of stories. We looked at Lord Darzi's report and we very much liked his description of some legislation in 2012 as a calamity without international precedent. I thought your ChatGPT should have picked that one up. It was pretty good, that phrase. But one of the things that we noticed about that report was we're a bit shocked, actually. There are 16% fewer fully qualified GPs in England than in comparable high-income countries like Australia, New Zealand and Ireland. We didn't know it was that bad. Keir Starmer, in his response, said moving healthcare back into the community, the focus away from hospitals, we agree with entirely, but everyone said that before. It's a matter of whether it actually ever happens. We were very interested in view on moving the NHS from an analogue to a digital system. Again, we have heard this all before. The UK has gone through many different healthcare IT rollouts, some infamously poor, which we won't mention. So we decided to poll our readers on the weekend what they thought about whether it was possible to save the NHS by moving from analogue to digital. 80% said yes. We didn't get that many quibbles, but it's a matter of putting words into practice, and the UK has had problems in the past. In Pulse IT's Ireland News edition, we covered a new report out by the Health Information and Quality Authority, who surveyed 2,000 consumers, 1,020 professionals, about their views on digitisation of health services, if there were any major barriers to that. And there were similar findings to the rest of the world, where consumers overwhelmingly think that an online health record will help them, but health professionals don't think that their patients have the digital literacy to actually understand them. So nothing new. We've heard this all before, but in this survey, the professionals themselves admitted that they needed help with digital tools as well. We also had an update on AI medical scribes. They've taken off like wildfire around the world. Here in Australia, our market-leading general practice management system has had a medical scribe integrated into its system since February. And we had an update on that just 2 weeks ago, and they're adding some really interesting new functionality. The AI third party doing some great stuff. When people have a strong accent, a different accent, the AI can handle that so easily these days. It's just remarkable. But if the consultation is in a different language, it's able to listen in and translate that into English notes for the patient record. Again, quite remarkable technology. We wrote a story on that, and immediately we heard from a rival medical scribe company saying, we had that months ago. It's a very competitive market. I remember listening to Simon from Nuance back at HIC in 2019 when he was talking about ambient clinical intelligence, and I'm saying, what's all this about? And he's saying, it can listen into your consultation and write a patient note. He showed me how it worked. That has come along a long way. Generative AI has really boosted it even further into making it a tool that GPs are using today in their clinical practice. And it's only going to explode even further. And that leads us actually into another big topic in Australia in the last week or so. We've had a new Aged Care Act that has been passed our parliament. We've had a big upheaval of our aged care system since the Royal Commission into Aged Care Quality and Safety handed down some pretty devastating findings a couple of years ago and some really good recommendations, particularly about the use of digital technologies and how it can help aged care, particularly residential aged care. But these days, the focus is very much on in-home aged care, keeping older people at home for longer. But there's a little pilot that the Australian government is going to run about automating what are called monthly care statements. They're a voluntary thing at the moment, but each residential aged care home is going to be encouraged to do a monthly statement for each resident on any changes to their care needs, what care they've been accessing in that month, and anything of relevance that they can then share with the family at home, any carers. And it's a great way to help residents keep track of the care they receive. But as we know, aged care providers are really worried about the documentation burden that this is going to have. It's going to be yet another report that they have to produce by overwhelmed nurses and care assistants. This is where technology can help. So the government is going to run a pilot on getting clinical software to be able to do these monthly care statements. And I know of one software vendor that can do it already. But I reckon AI could really make that move a hell of a lot faster than expected. That's our week in digital health at Pulse IT.
Oh my God, Kate, you always have such you go, nothing much is happening. And then actually heaps is happening.
It is happening. Aged care is a fascinating area, isn't it? It's an area where I think technology can do so much good.
Well, we do hope to have some very influential people. I think you made two really good points there, Kate. Tools which make the clinician's job easier, enabling them to spend more time doing what they train to do is critical. I saw that in action a few weeks ago where they literally enabled this amazing aged care GP to speak to the family, capture some information about a client, develop a care plan without sitting there typing on her computer the whole time, and just enabled a whole different types of communication. And when you look about the monthly care summaries, I mean, when that was first announced, the aged care providers panicked because they sort of went, well, now we need to get the people who we're short of, who are providing point of care services, to then go and type it all back into a computer. And these people didn't sign up to become aged care providers to type into a computer. So by using these tools, we take away that burden. We open up transparency because we make that information available, because at the end of the day, unless we know what's happening in an aged care facility, we can't correct it. So I think these are great examples of the tools. And kudos to Pulse for making those sort of things visible, because monthly care statements probably wouldn't have got voice in unless someone like Pulse makes it obvious to people how important it is to do this effectively.
They're not sexy, are they, monthly care statements?
Exactly. It's especially when they're accompanied by a monthly invoice as well.
But it's improving the communication as well. It's something that you guys talk about all of the time, is the improving communication between family and healthcare professionals. We've got an interesting comment on LinkedIn about the fact that it can translate different languages into English. Someone was concerned about the safety aspects of that. I think we need to emphasise, and I should remember to do so every time we write a story about medical scribes in particular, the doctor has to check and make sure that what's being put on the record is correct. And I think that goes without saying. The doctor has to check that the information is correct.
Yeah, it's about clinical governance. So I'm like you, Kate. I don't know any single clinician that would actually just go, okay, this is what the scribe said. And I've had a cursory look. I didn't really take it in. And now I'm actually using it as a core part of the record. So hopefully no one will do that. But yes, definitely do not do that. Another public service announcement from the PulsePod.
Do not do that.
Thanks so much, Kate. Full stories. And yes, we will come back and talk about AI scribes in another episode. So be keen to see what you're learning about that.
Fantastic.
George, another full episode. What do you think?
Lots of interesting stories, lots of interesting dilemmas we're facing. Clinical governance came up, communication, transparency, cool new gadgets that are revolutionizing the world, and then, a report which told us the same thing, which their last half a dozen reports have told us. So I think we are moving forward. And like I said, I've got my first document in my health record, so we are moving forward. I think it's exciting times, but like I said, we can't take our foot off the accelerator quite yet.
No, still lots of work to do. So let's get back to it, George. So in the meantime, can you please read us out?
Thank you for listening to Pulse, brought to you by Pulse IT News. Pulse is produced by Ivan Jurek of Octopod Productions. Thanks to Nigel Chartres, Emily Mara and Kate McDonald for contributing to today's episode. Subscribe, follow and rate Pulse wherever you get your podcasts. You can subscribe to Pulse IT magazine at www.pulseit, or one word, .news. Send your feedback and questions to PulsePod at pulseit.news.